in comparison, the autologous allogenic stem cell transplant is where you use a graft, a donor for a stem cell transplant. And the principles of allogenic stem cell transplants are, number one, having a donor which is healthy enough to donate and they do not have any disease. Could be a related person, a sibling, or an unrelated person from a NMDP registry. And I encourage everyone who is listening, if they are healthy, to consider enrolling on NMDP registry for being a donor for stem cell transplant. It is free and it's a great service to humanity. The cancer control in allogenic transplant, in autologous transplant, it was only chemotherapy, high dose chemotherapy. In allogenic transplant, you do immune mediated cancer control as well by something called GVL, or graft versus leukemia effect, in which the graft you put in from the transplant actually surveils and finds the cancer cells and kills them. And that's the principle of allogenic transplant, and that's what makes it the most primitive form of immunotherapy. All the new immunotherapies that we're doing, CAR-T or T-cell, tumor-infiltrating lymphocytes, all that is kind of a new version of the old immunotherapy, which is allogenic stem cell transplant. As I said, allogenic transplant is very dynamic. This graft that we give works as a new organ, a new transplant, and it helps us to fight the cancer cells. And then all the graft versus leukemia effect that we get from these transplanted cells, transplanters, allogenic transplant, helps us fight cancer, but at the same time, it can produce something called a graft versus host disease, which is what is the biggest comorbidity or biggest problem of doing allogenic stem cell transplants. If you have high GVHD, you have high chances of graft versus leukemia effect. So we want to get somewhere in between where we have a lot of graft versus leukemia effect and very little graft versus host disease. Some evidence if the allo transplant does work, so it does. We have big CIBMTR studies which host the largest data of allogenic as well as autologous transplants, and we see that the probability of patients being alive at 5 years from AML in the cohort of patients that were transplanted between 2008 to 2018, the patients who had transplant in their first remission had about 60% survival compared to the patient who never had a CR or relapsed after that. They had the worst survival. And that is also true for acute lymphoblastic leukemia, for aplastic anemia, which is not a malignant disease, which is not a cancer, rather an immunological disease. Transplant outcomes are way better because we do not need to have that graft versus leukemia effect, so we manage it a bit differently. And then with time, with each passing decade, we are doing better on doing an allogenic stem cell transplant, and our patients are living longer with that. So some requirements about successful allogenic transplant. Number one, to have appropriate disease indication. Allogenic transplant, unfortunately, is a very toxic treatment. And when I do allo transplant consult, these are the few things that I discuss with my patient in a long detail on the first consult as well as in subsequent encounters. The major indication for an allo transplant at this point in 2024 is either acute myeloid leukemia with adverse or intermediate risk characteristics, or myelodysplastic syndrome. And for other diseases like non-Hodgkin lymphoma or Hodgkin lymphoma or multiple myeloma, allogenic transplant is very rarely used. In pediatrics and in young adults, aplastic anemia is also an important indication. Availability of suitable donor. So about 20 years ago, our major donor source was a sibling who had complete HLA match. HLA is a special typing that is done on white cells. So that was our major donor source. Now, in last 20 years, we have expanded our donor source to unrelated donors a lot. We have gotten better doing HLA matching, and we have a registry of about 30 million people in US as well as around the world. Uh, if you if you are a white American, you have about 77% chance of finding a unrelated donor in the registry. But unfortunately, if you're one of the minorities, your chances of having a donor fall down to like 20 to 25%. So if you do not have a unrelated match donor and you do not have a sibling, those patients about 20 years ago only had a cord blood donor option, which was also not very good. So a lot of patients did not have a good donor options. But with arrival of something called an haplotransplant, which is also a sibling who is a half match or a parent or offspring they always have a half match to the patient or the index case. So that has expanded our donation options a lot. So the disease and the host should be in optimal state for transplant. If your disease is completely controlled, you have much better chance of doing well with transplant compared if you have active disease. With the host characteristics, like we need to make sure that the patient is healthy enough to do the transplant. Having good heart function, good lung function, good liver function, kidney functions, these are all things that are tested before transplant to make sure that we get the patient to do the transplant only if they are fit enough, because we have found over time in a lot of studies that if we do transplant in patients who have suboptimal organ functions, they do even worse than not doing transplant. So in those situations, we tend to avoid this toxic treatment. Conditioning regimens are the preparative chemotherapies. So we do it based on the patient disease and other characteristics. GVHD is a form of problem that happen with allogenic transplant, in which the donor cells that come from the graft, they attack the patient's organs, and we do prophylaxis with immune suppression during the beginning of transplant, and we give a very aggressive supportive care in especially in the first 100 days with antibiotics, blood transfusions, keeping a good control of the environment, vaccines, and everything. And then long-term follow-up and survivorship is important for allogenic transplant. Kind of went over the indications. AML and MDS, MPN are the major indications for allotransplant. Donor selection. Few things about donor selection. Sibling donor is still better than unrelated donor, and unrelated donor and haplo donor are kind of equivalent, especially with the new things that came in the transplant world. Younger donor is better. Male donor is better than a female who has been pregnant, because pregnancy gives a lot of antibodies to females. Infection status is important. ABO type is semi-important, and overall health of donor should be good. Histocompatibility or HLA matching, which is a special sort of white cell typing, is a prerequisite for doing a good transplant. So kind of go over these things. These are the trends of how donors have been selected over time. So if you see this blue curve is the matched sibling donor. So historically, the biggest source of bone marrow donation or stem cell transplant donation was a matched sibling donor. In around mid 2005, the unrelated donor picked off, and it is the biggest source. And now in 2019, the other relatives of, or most likely half matched donors, is meeting the match-related donor options. This is probably because we are doing a lot more transplants than we were doing back in 1990s, because if you do not have a sibling donor, then your options were very, very limited. As I said, disease control should be optimal. We like patients to be in complete disease control before transplant, but if that cannot be achieved, minimal disease state is important, and then the host or the recipient should be young with minimal comorbidities. This is a score which is called Hematopoietic Stem Cell Transplant Disease Index, or Comorbidity Index score, that was developed back in 2005, and it has different risk factors that are given based on a training and a training cohort and a confirmation cohort, and we found that if patients have higher risk factor of diseases, they have worse outcome with the transplant. So if someone is having really bad liver, lung, or heart disease, that's why we don't even do transplant on those patients. Conditioning is what sort of chemotherapy the patients get before transplant. So you get a myeloablative, which is a strong chemotherapy, or a reduced intensity conditioning. What I do is I prefer myeloablative conditioning if the patient can tolerate, but if they cannot, then reduced intensity or non-myeloablative conditioning is pretty good option as well, with the caveat that the chances of disease coming back are higher with the reduced intensity conditioning. Some common regimens for graft versus host disease prophylaxis. This is something our patients listen a lot, especially when they have when they're undergoing the allogeneic stem cell transplant. We have different types of regimen. The thing that came out very recently is called post-transplant cyclophosphamide, and this has definitely revolutionized the care of these patients, because the long-term graft versus host disease or chronic graft versus host disease has decreased a lot with post-transplant cyclophosphamide use. Supportive care, very, very important. The main reason the patients are living longer and better after allogenic stem cell transplants. You do transfusions, you give a lot of nutritional support, infection control, extremely important, antibiotic prophylaxis, precautions, environment control, and if there is any fever or anything, aggressive management. Treatment of other toxicities, growth factors, strength and conditioning, especially in the elderly, is extremely important for these patients, especially in the after transplant in the first 30 to 100 days. And then keeping an eye on what medicines they are taking, so you reduce the exposure to multiple medications, and that way improve the outcomes of the patients. For after transplant, I get my patients back once I keep them in hospital for about 30 days till their white cell counts recover. After that, I get them back twice a week in my clinic for another 30 days, and then and start doing once a week after that till about 6 months, and then we slow down after that if there are no complications. We monitor very carefully for toxicities during those visits. We talk about, we restage the disease multiple times, make sure the disease is not coming back, and then taper the immune suppression if they don't have graft versus host disease. Start doing the baby vaccines again, especially focusing on the big childhood sort of diseases and hepatitis B, pneumonia. These vaccines are extremely important. COVID vaccine is extremely important. Flu vaccine is as well. So all these vaccines are done about 3 to 6 months out of allogenic transplant. And if the patients are relapse free at 1 year, and so that always is a very important time mark. If the patients live till 2 years without disease, the chances of making to 10 years becomes about 85%, which is amazing.